Right.
Yeah.
I'm going to pass you over to Pauline in a moment, just to give a bit of an introduction to the to the background to the work that I'm going to talk about. But just to quickly run through what we're planning on speaking about today. Pauline is going to give a bit of a background to the end of life, the Derbyshire end of life strategy, and the plans for a single point of access or SPA. Then I'm going to talk about what we've already heard from patients, carers and staff, and the context that that information was collected in, and then just a little bit at the end about how we plan to continue our engagement, because this is very much a starting point today. So without further ado, I'm going to pass you over to Pauline now, just to give a bit more background.
Thanks, Lenny and Sue. I'm sorry about my background. It's probably bright. I'm in my car. I got stuck at an appointment that I couldn't leave. So I'm Pauline. I'm a GP in Bakewell, and I'm the end-of-life clinical lead for Derby and Derbyshire CCG. And I'm also end-of-life clinical lead for East Midlands for end-of-life. So I wanted to just have your views, really. We're very, very keen to get your views around what's happening with end-of-life within Derbyshire and how you can help us to help the systems. So I'm not going to go on forever because I can talk about end of life forever. So basically, I'm not sure if you're aware, there's been a recent Health and Social Care Act passed through Parliament, where end of life care is now a mandatory requirement for all ICBs, so integrated care boards. So Derbyshire CCG will soon become integrated care board on the 1st of July, that's Friday. So we'll have certain mandates from government, and one of those mandates is end of life, and I'm really excited about that because end of life has not been mandated previously. So this is our opportunity as generalists, people working in the health service, you as prospective patients of end of life, because two things are guaranteed in life: we're all going to pay tax and we're all going to die. So we need to get it right for everybody. So we really need your voice in what we're doing. So the Integrated Care Board is the overarching board that looks after every aspect of health, social care, you name it, voluntary sectors, charities. We all work together in the integrated care system. The end of life
Right.
Have we lost Pauline?
Do you want me to try and carry on?
Yeah, you try and carry on, Sue. That'd be great.
Bear with me. Pauline's a lot more eloquent than me on this part, which is why I sort of volunteered her. But yeah, I mean, I think you've already sensed some of the passion she holds for the end of life care in Derbyshire, and
integrated,
also we're back again. No.
You carry on, Sue. I think we'll have to.
Yeah, and also the importance of making sure that local people do drive the development of services. What we had identified when the review of services was commenced, which was prior to the pandemic, seems a long time ago now, was the variation, the inequality in services for end of life across the county. And this was by geographical location and also by the conditions that people were suffering from at the time. So this county-wide review aimed to ensure consistent meeting of the agreed standards. These are the standards that have been set by NHS England, and provide the care that people need, and also the care that people want, their choice of care, to die comfortably in the setting of their choice and with dignity. The idea was mooted at that time for a single point of access or SPA for patients that need end-of-life care and support. And the beginning of this work was really to look at what the spa should look like, what services should be provided, how they should be provided, what was most important to people, what should the spa look like. So the end of life board had a number of work streams working to it, and I lead on the what is now the People Driving Change work stream, but was then the experience work stream. And we were asked at that time to identify some fundamental outcomes that were important to dying people and the families and people involved in their lives, and that these would inform the whole of the Joined Up Care end of life delivery plan. So as a result of that, and bearing in mind this was all prior to March 2020, when life changed in a very unplanned and unrecognisable way. But we decided then to do a huge piece of work through that summer, looking at talking to people with lived experience of end of life care, to start putting together a picture of what end of life care and what the single point of access in Derbyshire should actually look like. So we started this work, and it very soon became apparent that things were going to change that summer. Staff were redeployed. A lot of the end of life care, the sort of strategic plans for it, were stood down at that time. But we tried to carry on regardless, and we did manage to put together a piece of work. We did manage to speak to quite a lot of people, and we got a completely different flavour that we weren't kind of planning for, which was how the pandemic, how COVID-19 and how the way that services were provided was also affecting care at that time. What we need to do now is move on again and build on this work that we already started. But I just want to run through the work that was done in 2020 and the findings, and then tell you how you can get involved and to help us build on this and help us develop services that are second to none across the whole of Derbyshire with no inconsistencies at all. So the first thing we started doing early in 2020 was looking at the existing national and local data. We did this as a benchmark really to see what was going on elsewhere in the country, what people's experiences were and how we matched up and what the similarities and differences were in Derbyshire. So I'll run through in a moment what we found nationally compared to what we found locally as well. But on the basis of the data that we gathered from the wide spread across the country, we developed 2 online surveys. By this time we were in pandemic, so we knew we were going to be quite limited into, you know, the sort of methodologies that we could use and the people that we were able to speak to. But the two online surveys were based on what we'd found out in order to make a comparison. One of the surveys was for patients and families and carers to hear about their experience, what they were going through or what they'd been through with a person at the end of life. And then the other one was completed by healthcare professionals who also managed to give us a really valuable insight into what it was like from their perspective, what it was like as a patient, because they also had a really good perspective into how patients were feeling, because it was such intense care that they were providing, personal care that they were providing for people, and also how it felt for them, the challenges, what was working, what wasn't, and what was missing, where the gaps were. So we promoted these surveys through social media. We targeted emails to various stakeholders that we'd identified so that these people could share the surveys for us, and also gain consent for us to speak to patients so that we could carry out semi-structured interviews and get more information from people that consented to it, and also with a view to putting together patient stories as well, where people had particularly complex and sort of long drawn out experiences with end of life care, because that was the way that we decided we could capture the most information and actually bring the experience to life. So we identified individuals. We didn't actually do the patient story part at that time, just because of limitations on time and staffing, you know, the staff that were experienced to do it. But we did also carry out a number of semi-structured telephone interviews, bearing in mind we couldn't meet people face to face, and a lot of patients and carers still hadn't really got to grips with the technology involved in these sort of meetings then. The research was obviously limited. There was a lot of demographic groups that would have liked to have spoken to and actually couldn't, because we were still finding our way round sort of the limitations that the pandemic was placing on us, and also the staff shortages due to redeployment. We were all redeployed to support things like supplying PPE to care homes. I mean, these were my personal experiences, and then later on with the vaccination programme. So we were very much dropping in and out of it through that first summer, but we did manage to produce a report by November 2020. So just back now to that review of national data. I don't know if people that are with us today have had experience of end-of-life care, caring for a loved one or in a professional capacity, and whether there's any big surprises here, or whether you're going to be sort of quite feel sort of quite upset when you hear this. But it was an uncoordinated approach to palliative end-of-life care, and again, this was due to differences in conditions. So I think the care that people were receiving for their condition, rather than specifically the care that they were receiving at the end of life, it wasn't very joined up, that transition then into end-of-life care. There was a feeling that end-of-life conversations aren't approached by professionals at the right time, and also that carers and family members aren't listened to, and they're very important in this type of care, because they are, no matter where a patient has chosen to be cared for and chosen to die, carers and family members are a huge support network, both for the patient and the staff providing the care as well. Most experience of care plans seem to be that they weren't holistic, that they were very much sort of centred on specific aspects of care that was deemed important by carers and healthcare professionals, and not looking at the bigger picture, other problems that people might have as well, financial problems, who was going to look after their dog, you know, when they couldn't do it anymore, just things like that are really important to people, and who was going to do the shopping, just things that are really important to people on a day-to-day basis that we tend to overlook sometimes. And along similar lines, bereavement support, when it was offered, wasn't actually used to address these kind of issues. It was more just about talking to people about what you know, what to expect, and about the condition, and what to expect from end-of-life care, but it didn't actually specifically address some of the real concerns that people had. They knew they were in the end of life. There's nothing that you can do to change that, but obviously they wanted to make sure that everything around them was looked after as well as possible, and that they didn't sort of run out of money. There was concern for care with people with disabilities or other needs, and we tried to do some work. We looked at doing some work around the specific characteristics, but it just proved impossible. So this is going to be part of the next part of our plan now. There was a large number of hospital admissions in the last 3 months of life that could be avoided, and staff were very instrumental in telling us what was causing this. So I'll move on to that in a little bit when we talk about what our surveys found out. And also a lack of joined up care, and that was in particular with young people moving to adult care services. So the care sort of stopped, you know, as it were, and then they had to kind of find the way all over again if they reached the age of being an adult during the time they were receiving end-of-life care. So again, young people is a group that we have identified that we need to do more work with. When we talk about joined up care, I think we all know that term now. It's care that just isn't about different agencies taking responsibility and passing people on, saying, oh, well, this isn't us, you need to speak to somebody else about this. It's about the care that is provided to that person being seamless and joined up and for the person receiving the care. So nationally as well, gaps in data were identified for children and young people, people with physical and learning disabilities, the prison population, and we did link in with prisons and made some good contacts, but again we didn't actually manage to get into talk to people at that time who were receiving end-of-life care in prison, so that's something we can maybe pick up again. And also care home residents, as you can imagine, that was a very difficult group of people for us to reach during the time of the work we were doing, so again flagged up to approach care homes as the second part of it now. So our local findings just about reflected these identically really. And healthcare professionals did provide a valuable insight into enablers and barriers that would ensure consistency of care and also prevented them from providing it. Good communication across the system does lead to effective joined up care planning and holistic support for patients and their families and carers. It's not rocket science, and it's really important, and hopefully now, you know, with the new structures that come into place from the 1st of July, it will be easier to people to communicate across the organisation. Now we're all going to be part of one organisation and all working a lot more closely together. The unplanned hospital admissions that was such a sort of negative aspect of national findings. The staff told us particularly that these often arise from emergencies and crises in the home. This is when people fall, when families and carers get so stressed and they don't know where to turn, and they feel suddenly that they can't cope anymore and it's beyond them. Unclear treatment plans, so when you've got various professionals involved and a treatment plan that one person's one agency or organisation has provided for a patient doesn't make sense to another part of the organisation, they can't implement that. So there was an awful lot of pitfalls in joined up care really for people and families. The families and carers we spoke to, it was just such a difficult time for them. I think in some cases it was more difficult for them to kind of manage and cope than it was for the actual patient that was at end of life, because they felt that they had so much that they needed to be able to do and just felt that it was beyond their capabilities sometimes to do it. Families are often the main carers for end of life patients, and care networks can break down when they don't know how to access support and information in a crisis. So again, the single point of access is really not just for patients, but it is for their families as well. We did note, unsurprisingly, that COVID did impact on end-of-life care in a number of ways, but it was still interesting to talk to people at this time and just find out a bit more how it was impacting them. Obviously less contact with GPs, people were really feeling that, and other healthcare professionals such as district nurses and health visitors and people that were coming out to see them suddenly stopped. You know, they suddenly stopped being able to see them face to face, and it did leave patients and families and carers feeling really, really isolated. Patients and healthcare professionals recognise benefits of an individual care package that's holistic, but we do need to address some of the barriers before this can happen. I'm not sure that without getting all the people that would be involved in a holistic package of care together, that all those people who provide end-of-life care would necessarily know what a holistic package was. And also holistic should be personal to the patient as well. Different people need different things depending on conditions and the condition that they've got and what their choices are really for dying. There was a lot of positive feedback about care and support given by hospice services. I think people felt that they really did understand, and although they were really stretched, they felt that they got a lot of practical and emotional care and spiritual support from the hospices that they weren't getting from elsewhere within the system. There's not really a lot more to say. I just wanted to sort of keep it quite simple today. We can provide the report to people if you're interested in seeing it. That kind of just breaks down the questions and the answers to the questions a bit more, and contains a lot of patient and quotes from patients and staff. I'll just pop this up on the screen for now, just to sort of pick out again the words that you would expect to find there, but these are the recurring words through our findings, and these are the things that people wanted. These are the things that people felt were important for a good end of life experience, and we've got that holistic care's in there: support, kindness, well-being, honesty, important, thoughtfulness, hospice care, calmness, trust. There's all sorts in there. So that is really a summary of the recurring words throughout the report, throughout the findings that we got doing that work. So the reason for bringing you together to hear about this today was we're wanting to take this work forward now, hopefully in a more unlimited kind of way. So whilst we have done our own work around identifying groups and people that were missed before, we still want to talk to as many people as possible. If you've got lived experience of end of life care, we do want to hear from you. We want to hear about this experience. Just can either be confidentially, give us as much or as little information as you want to. But we do want to hear from you. Did the care meet the individual needs and choices of the patient? If they chose to die at home, was that possible in the end, and was it a good choice for them? Did it meet the expectations of the patient and the people around them? If they chose any other way to die, did that care meet their individual needs and expectations? Was the right support available at the right time? Possibly not. If you look at the whole care package, there may have just been, it may have been overall been good, but there was one little thing that could have made it better. Again, we want to hear about that, because what we're trying to do is look at the single point of access. What should it look like? What are the services that should be provided from there? And most importantly, was there anything missing that would have improved the service for the patient and also the family and carers? So even if it's a service that isn't actually available yet, but it's just something, and it can be the simplest things sometimes that can make all the difference. It doesn't have to be clinical, it doesn't have to be medical care, but any one or two things that were missing that would really have improved the experience for people. I've put my contact details on there. I've put an email address because I only work part-time, so it can be quite difficult. And I've only got mobile phones, so it can be quite difficult sometimes giving a phone number and managing that. But I would be if people can drop me an email, I would be quite happy to talk to people, or get a colleague to talk to who's working on the project as well, to talk to people in more detail about their experiences. In return, we will carry on sharing the feedback with you and how this SPA develops, and we will feed back to you individually about how your feedback has been used. So can't see the chat when I've got this up, so I don't know when I've got the slides up, so I'm going to come out of the slides shortly, and then I'll have a go without Pauline, if she's not back in the meeting, at just answering any questions that people have got. Anything I can't answer, as Lenny said, we can find out the answers for you. So,
I'm back. I'm not sure if you can hear me.
All right. Yeah, I can hear you, Pauline. Thank you.
Sorry,
I can't see anything when I've got the slides up. I can't see.
I came to park into a local crematorium because it's quiet and I've got signal, so I do apologise.
Oh.
It's apt for the discussion that we're having.
Yeah. Did you want to add any? I don't know how much of what I was saying you heard, but is there anything you want to add that I might have missed, particularly in the introduction?
No, I think I was trying to find somewhere with signal. Sorry for the introduction, but yeah. So basically, we've got a statutory right to do good end of life care, and Derbyshire are good because we have got end of life care on our agenda. We're looking at our strategy and refreshing it, so we need the voice of the people to help us with that strategy. And as a board, and obviously Sue is a big part of our end of life team, and so is Lenny. We need that voice so we can feed up to all of the system, and that's everybody, about what you want us to do. Now is the perfect opportunity, because that law has been passed that it is mandatory. So please tell us any different things that you need doing. So yeah, I'm very excited about the chat.
Thanks. Right. Okay. So so Lenny's going to circulate the report with the recording after the session. So have you got that report, Lenny, or do I need to forward it to you?
I believe I have that report. I believe it's also on the Insight Library as well. So
let me know if there's any problems.
I will do.
It'll make more sense now. People have kind of heard the background to it, I think, because otherwise it looks like quite a sort of unfinished piece of research, which I guess it actually is. So yeah.
So Steve has asked, you mentioned positive feedback about hospice care. Has there been any study of what hospices do well and what can be learnt from them for the ICS? I'm guessing it was more on the soft side of EOL care than treatment, etc.
Yeah. Again, that's something I can find out about if you like. I can sort of take that away. I think probably the best thing to do is produce a sort of a question and answer from this, because I'm sure there'll be a lot, with it being so diverse, I'm sure there'll be a few things that we can't answer. So I'm quite happy to find out about that for you. There's nothing that I'm aware of. I don't know about you, Pauline. Sorry, I'm
no, I'm not sure about research. I mean, there's been lots of studies done in hospices, and interestingly, there are a couple of hospices in Yorkshire that have actually not got a very good CQC rating. So I'm waiting for their rating reports to come out so I can have a little look at them. But we've got to bear in mind that hospices are run by majority of the charitable funds. Some is NHS funded. They have more staff ratio to generalist end of life care. And if you look at the research, 5% of the population would die in a hospice. So that means the other about 40% within Derbyshire, about 48% die in hospital, and the others die at home. And we're pretty good in Derbyshire for people dying at home or their preferred place of care. So if you think of the whole population, only about 5% die in hospices. Their ratings are good because they've got that excellent one-to-one care, whereas we don't get that in generalist services or in hospitals. But we want to shape things so we are as good as that, and we've got lots and lots of ideas. I've got lots of ideas of how we can improve end of life care, and for me, I want more of a joined up service. So if there's lots of questions, I'll shut up, but for me, we have lots of fantastic areas of care within Derbyshire. It's not all as joined up as it could be. We've got great providers in community from our DCHS colleagues, which is our community nurses, from our out of hours colleagues, which is the palliative care urgent response car. We've got the dementia and palliative care response service for end of life, all fantastic services, and trying to communicate better. But we need those higher up people, those chief execs, to listen to us, to say we need a proper joined up care Derbyshire. For me, I'd like one massive generalist end of life team with multidisciplinary team meetings and more care at home. But they're just my thoughts. But we do good care in Derbyshire, and looking at the rest of the Midlands, we are quite far ahead of other places.
Yeah, I think that really balances out, because I'm sort of reflecting now how just presenting those findings so briefly, it sounded quite a bit negative, and I think it's important to say that where it's working well, and it's just sort of working well in pockets at the moment, isn't it, in some places? And I think it's really, as you say, it's the joined up seamless care that's the most important thing to get right. So
absolutely, and we do get some complaints from end of life care. To be fair, in the years that I've been doing end of life care, we've probably had 3 big complaints around end of life care in Derbyshire. But majority are good things that are happening. Like I say, in pockets, there are areas that we need to work on. Black and minority ethnic groups, prisons. And interesting, I was on a talking with NHS England in London yesterday around prison populations and how we can help serve better the prison populations. So there's lots of work happening out there, but we just need your voice to make sure we are going in the right direction. And I didn't think it was a criticism at all. I'm very quick to criticise my own end of life care, thinking, why didn't I do that sooner? Why couldn't I have done that better? But that's part of life, isn't it? You know, we strive to do best things, especially for people that are dying.
Andre has asked, do we have a timeline for the further development of the SPA, and can organisations outside the CCG be involved in this work?
All organisations are involved in this work outside the CCG. That is it. I'm probably the only one that sits on the single point of access work stream. We've got a work stream with all of our providers. We try to get ambulance service. We're trying to get voluntary services, and we do get some voluntary services. We've got hospice representatives on there. We've got community representatives, we've got educators, and we all sit on there to try and shape the single point of access. So for me, we need one telephone number that if someone's got an issue, they ring that number, and that's a single point of access, and that can be signposted onto either it's a dementia end of life service, it might be a community nurse that's needed, it might be a GP on the palliative care card that's needed, or it could be anything. But my aspiration is you don't do 25 phone calls for one thing. But everyone's on there.
Can I just, as a taking off my NHS hat for a second, how much getting affairs in orders, which can therefore have an impact on the mental health of somebody facing end of life, will be included in this?
It should be proactive care. So we should be doing proactive, not reactive care. So I'm working on with NHS Digital at the moment, and providers from around the whole of the Midlands around advanced care planning. So, you know, advanced wishes, how people need to be looking forward to what they're doing. So I'm only 57. I'm fortunate that I'm in good health, but I have got a will and I have got a care plan. So my husband knows I won't cremate him. So my care plan would be, at the moment, you know, resuscitate me because I'm only 57 and I've got hopefully lots of life. But please cremate me if I am dying. I want to die at home with my cats in my own bed. So that would be my care plan. I'm thinking for the future. We all too often get those crises responses, so people become very unwell. And when you're unwell, it's harder to talk about what your wishes are. And we need to proactively do that talking, that planning, and that aim for better care that way, because if we don't know what our relatives or our partners want, we can't plan for their end of life experience.
Absolutely. That's the drum I bang. And speaking of drums, Nick Cutts has said Opus Music CIC is an organisation of healthcare musicians who specialise in music making for improved health and well-being. Done lots of work in the past within acute care with people at EOL, along with training on use of music for healthcare professionals and carers. Music and music making have proven positive impact on the whole person, physical, psychological, spiritual, cognitive and social impacts. I'd like to see music as an important part of holistic care, not just a nice to have.
And I fully agree with that. And I've just passed lots of information to our care homes lead in the Dales around that to see how we can better utilise that. I think it's really important, and obviously pass on my details. I'm just pauline.love@nhs.net for anything like that. I think this could be a really good part of our single point of access and part of the provider the services that we provide for people.
Absolutely. So you can just take the slides down, could you, just so we can get a bigger screen?
Oh, sorry, I didn't realise.
People. Lisa said, are there any plans to obtain the views of patients, care agencies, providers who live and cover the Glossop area? Because obviously Glossop has now come into the Derby and Derbyshire remit, and they weren't when we did the initial survey.
From my point of view, Glossop is part of Derbyshire, Joined Up Care Derbyshire. We're not calling them CCGs from Friday, part of Joined Up Care Derbyshire. So I'm all for it. If someone's got a voice and they want to join some of our work streams, please let us know. We had 2 fantastic people representatives on our work streams, and they've retired from our work streams earlier this year. So we are looking for a voice to come and join our work streams.
No, it's okay.
Sorry, somebody's not on mute.
Is he? Yeah, he sent me another bloody email. Well, yeah, because he's not happy that
Somebody isn't on mute and they're on the phone. They might want to turn them, make sure they are. Okay, so let me just have a look. Sharon Watson has mentioned the Derbyshire Alliance for End of Life Care. And Sandra has said it's all part of personalised care, listening to what matters to you in advance. Absolutely.
Yeah.
Absolutely. And the Derbyshire Alliance for End of Life Care is very interested people that kind of represent lots of different providers, and we look at all sorts of things. Sharon's the chair. And we look at education and how we can improve services. So we have a toolkit, the Derbyshire End of Life toolkit, and if anyone can use it, anyone can look at it. There are resources on there, so please have a look at it. Just put Derbyshire Alliance for End of Life Care, that'll pop up, and it's a fantastic resource. And the people on that group work tirelessly to improve care for people within Derbyshire and Glossop. Just going to go under us.
Yep, so we've got solicitors drafting wills are an opportunity to make their wishes known or at least recorded. They absolutely are. I think yeah, there's lots of people who are involved in this, in the aftercare and the solicitors, you know, and just making sure that people can kind of almost put that to bed and know that their wishes are going to be followed up. Just help on a mental health kind of route.
Absolutely. I'd like to see more as well around bereavement, because that's a huge issue at the moment. Bereavement services that were prior to pandemic are overwhelmed post-pandemic now, and I think this is a golden thread throughout the country, that all different integrated care systems are looking at their bereavement services. So I think that's a huge part as well.
Absolutely. You're still sharing a screen, Sue. We've now got kind of...
Oh God, you can tell I don't do this very often.
We've kind of got you in an everlasting mirror kind of image.
All I can see is, but I can't even see the slides now. Oh dear.
There's an arrow, so if you press the...
There we go.
It was as simple as that. I was making it a lot more difficult than it needed.
We can see more people now. Are there any further questions? We've got any further comments or questions? Oh, Richard.
Right. This single point of contact, if a person, a relative, is firmly convinced that the end-of-life care was not delivered correctly and the departed relative was not killed, but could have been saved, because clearly not everything goes right every time. You know, there's been huge pressures on staff and people have died unattended in hospital. Does that single point of contact record that the relative has expressed a concern or even a complaint, and is that actually formalised rather than it's a passing comment? Because if there's a lot of these things happening, what you find is a public inquiry, as you've got in maternity care, where years after there's been a lot of deaths, somebody said, oh, wait a minute, there's been 200 deaths at this hospital. Should we have a public inquiry? Well, yes, but we could have perhaps formalised all the complaints in the first place, and we would have watched this number grow instead of waiting until there's an enormous number and then being forced by public opinion to do something about it. So we've got an opportunity now, haven't we? Because we have this single point of contact, it is not for the nice things, it's for all things, surely.
Yeah. Pauline, have you sort of got any immediate response to that, or she frozen again? Right. Yeah. That's all right. I did. I'm not really sure how to approach that one because it feels really huge. But I think with the governance arrangements in the sort of across the system, I'd like to think that if there was anything untoward happening, any areas of concern, that would be picked up much quicker than some of the cases that you're referring to. Things like complaints.
It is a
PALS,
painful process.
Yeah, just general, general sort of patient feedback would alert us much quicker, I would hope. Again, it's difficult without sort of knowing all the background to some of these cases that have now got public inquiries going on. But organisations should have the governance requirements, the government structures within them to do things like this. But also, I mean, complaints because of the SPA. I know we've got complaint staff on the.
Believe you me, I've tried.
Is that Lise? Oh no. So
Somebody's got a really bad signal and I can't quite work out who it is.
Speaking. But we have got, I mean, I know we've got members of our complaints and governance staff on this call today. So I'm sure that they will be linked in with the SPA, and that if complaints arise, that will be the point of contact for investigating complaints and also reporting concerns as well. So I'd just like to try and reassure you, that hopefully it would never get to that sort of stage, but it's a difficult one to address that, and I can't really think of how we can respond to it at this moment in time.
I'm just going to come to one of the hands up. Yeah. Jane Morland.
Yeah, thank you. It's just picking up, Sue, just on the gentleman's points.
Yes.
I work in Royal Derby Hospital. I'm an end-of-life care facilitator, and we do have medical examiners who do review the mortality, the medical notes of the patients that have died within our trust. Yeah. And they do contact relatives. Also our bereavement services, that's where a lot of our relatives have initial contact with the trust. And again, there are governance structures, absolutely, that people then can raise their concerns if they have any. So I think just to reassure that the gentleman that was raising the point that, and you're right as well, Sue, we do have internal governance structures that do look at all deaths now. Yeah. So yeah. We don't get it right all the time, obviously, but we are trying. Yeah.
Yeah, it's difficult for me to sit here and reel off what every individual part of the system is doing, but I just hope we're able between us to have just provided a bit of reassurance.
Absolutely.
These cases that we hear about on the news, they are the exception rather than the norm, and
absolutely.
There's probably a backstory to them as well.
Thank you, Sue.
Got any more questions?
Oh, I'm muted myself. Andre's just said thanks for clarifying inclusion of organisations outside the CCG. Being from the voluntary sector, I would love it if this also included voluntary organisations who are not hospices. You may already do that,
I'm sure.
but let me know if you need help with signposting to relevant forums through which you could engage with further organisations. That's brilliant, Andre. Thank you.
Thank you. Thanks.
And Sharon's just replied with regards to medical examiner at UHDB. Steve's said, when my father died 10 years ago, the Liverpool care pathway still existed, but we were not given any information, nor was it made clear that he was put on it. I don't know if other care pathways still exist, but more information, choice and openness about such treatments at the very end would be a great improvement for families attending a dying person. So I think that's a really great comment, and
Thank you.
Leslie has said that technology can play an important role in helping patients, e.g. overcoming communication barriers, staying in contact, online resources, etc. Are there plans to include this in the holistic approach?
Yes.
Can you hear me?
Yeah. Yeah, it's how we do things now. Is that Pauline?
It's Pauline. I'm trying my hardest. We did look to model in Canada where they use technology. So they would have a base nurse and that would look after a huge area of Canada, and they would have nurses that would go out and see the patients, and they would Zoom or FaceTime or whatever they do over there. So that patient could give a view to the base nurse what was happening. It's something that we looked at many years ago, but we chose not to go down that route at this stage. But I think technology is very important. There are pockets of Derbyshire, obviously I work in Bakewell, where there is no technology, there is no signal, and some people don't have Wi-Fi, they don't have telephones. So I think technology, where it's due, yes, let's use what we need to use.
Yeah, we've all learned very quickly, haven't we, over the last 2 years as well, and patients and healthcare professionals.
Canada do end of life care very well. They even have an advanced care planning day, like we have Pancake Day, or they have an advanced care planning day where they encourage everybody to get out and make their plans. Which so they do look at this really closely, and they have a lot of good methods in Canada, I have to say. Any more questions? I think we've got another hand up. Just give me 1 second. Sharon. Sorry, am I saying your name right, Sharon? Sorry.
Hello. Oh, yes, you are saying my name. We just stick with Sharon because it's easier to say. I was just typing a response to Steve that shared about when his father died. Thank you for sharing that. To really say that 2013 was the year the Livable Care Pathway was removed. And absolutely, Steve, in response to that nationally, it is all about personalisation, honesty, openness and choice. And there is a lot of information on the Derbyshire Alliance End of Life Toolkit as well. Yeah,
thank you.
It's really, really important that we get this right as much as we can, and for feedback from everybody. Thank you.
Derbyshire stopped using the Liverpool Care Pathway probably 2 or 3 years prior to its withdrawal anyway, because I was up against the scrutiny board with police constables on there asking us what we used in Derbyshire, and we stopped using it probably about 3 years before it was withdrawn. So as I said, Derbyshire is ahead of the rest of the groups, hopefully.
Thank you. Michael has said, take heart, Derby. Sorry, when there's a new comment, it moves everything. Have more than 200 members, and about half do not have access to digital equipment. So the old-fashioned face-to-face methods are essential. And I think particularly on this kind of topic, face-to-face is incredibly valuable because it's such an emotive topic.
Yeah.
And we don't, while we want to make sure we're utilizing all the tools we have, I don't think we want to lose that side of things.
No, I think particularly for this next stage of the engagement work now, the face-to-face, which is usually the go-to option for engagement, was the bit that we had to miss out on while we were carrying out the questionnaires for the report. So I think it's really important that we pick up now what we weren't able to do with technology during that time. Definitely.
Yeah, Leslie has said during COVID she was unable to visit her dying dad, so only had access to Skype after a battle, and we need to learn lessons from the last couple of years. Definitely. Yeah, absolutely. Richard, I can see you've got your hand up.
This face-to-face, whilst I agree with it, you must remember that not all the population speak English, and not all of the deaf people in the population speak English or use BSL. There are lots of versions of BSL, BSL being predominantly for English-speaking people. I've raised the point before because there seems to be a lack of understanding about the diversity of the population. Not only do we not seem to understand how diverse the population is, but we have the added complication of the disabled people and deaf people who are also part of the diversity. We don't seem to have grasped this. And I fear for some of the minority religions. I mean, I worked in Leicester. You can imagine there were 65 religions and 65 languages. You can imagine how difficult it was just to hold patient group meetings, because we had to fit in with the prayer meetings, and it was a nightmare. And so end of life care was intensely difficult because they didn't have the right people with the right level of understanding about the process of death in minority languages. Death is a somewhat, it's viewed differently in some religions than it is in the Christian religion. I'm not entirely sure that we've grasped this.
I think this is the sort of thing that people like yourself can point us in the right direction with, and also this is where it's also important to have links within the voluntary sector and within communities that can help us with some of these issues as well. I think at some point very soon we are going to have to sit down and look at the groups of people we need to reach and how we are going to reach them, and this is what we were hoping. This is the sort of feedback we were hoping for from today as well. So whilst, as I say, we haven't got all the answers here and now, I will take that on board, because it is one of those things that, I mean, I don't know if it's not always practical for us to go out and talk to people face to face, especially when we, as you rightly say, we may not have the understanding and the cultural understanding to do it, but we do need to make those links with people that do have those links and do have that understanding. So you could, you know, we need help identifying them, I guess, is the answer to that.
But we do have a work stream within Derbyshire.
We're losing Pauline. I think she was saying that we do have a work stream within Derbyshire.
Oh yeah. Is it the
looking at those groups?
Compassionate Communities work stream. So maybe it's to do with working with them a bit closer. Yeah. I think for me, what I'm taking away from the sort of groundwork I'm doing at the moment is that we've got all these end of life work streams. We don't actually seem to be talking to each other, apart from updates at the group meetings. I do think there needs to be a bit more communication going on behind the scenes at the moment, and I suppose as part of the people driving change work stream, we're probably the work stream that needs to facilitate some of that. So yeah,
absolutely. And Leslie, if I can bring you in.
Hi, yeah, I was just thinking, I'm all for face-to-face meetings and trying to sort that out, but Derbyshire is a very long county and it's a long way to get to places. So I'm just wondering if there might be some way of doing a hybrid. Or
absolutely, absolutely. That this is what we're sort of identifying. There's no one size fits all. We need to find out. We need to identify. So do a bit of a mapping, identify what the needs of people are, who we need to speak to, and how we need to speak to them. So
absolutely.
Thanks very much.
Thanks, Leslie. Okay, any other questions? I can't see any in the chat that we haven't addressed. Lots of comments about accessibility is key, absolutely. Making sure that we're reaching into those communities, recognising that a lot of cultures do differently, and recognising that and have different requirements in end of life care. And that's really important to recognise as well.
Yeah.
So we've got 3 minutes to spare. I'm giving you 3 minutes back. I'd really like to thank you for coming along and engaging on this topic. It is a difficult one. People don't like to, in the Western culture, certainly don't like to talk about death. Kuljit has just said it's been clearly stated that BAME NHS patients in Derbyshire are left on waiting lists for longer. This has not helped with BAME getting the right support, absolutely. And all of this needs to be taken into account and making sure that we're making this accessible for everyone and fit for purpose. So I know that we're going to take a lot away from this, so really, really appreciate it. Thank you. We shall see you again. Just very quickly, our next Derbyshire Dialogue is actually on the 9th of August. This is going to be on, so as you may know, on the 1st of July, we transitioned to an integrated care system, and we will be feeding back on the first month of the integrated care system, what we've learned, what we've done, what actions we've taken. A link will be circulated shortly, but it should be a really good session. We've got Dr. Chris Clayton is coming along to talk to us, and the Joined Up Care chair as well will also be coming to talk to us about the first month within the ICS system. So that is on the 9th of August. I hope you have a lovely month and a bit. I shall put Pauline and Sue's email addresses in the email I'm going to send out as well. So you do have that contact details if you'd like to contact them directly. But thank you very much, everyone. We really, really appreciate it.
Yeah, we do. Thank you very much.
Thank you. Bye.